Gastritis, inflammation of the stomach. Yeah, I know, you probably didn't need me to say that. Gastritis can be caused by a bunch of different things. An organism called H. pylori has been implicated both in gastritis and in peptic ulcer disease. It's one worth knowing, but lifestyle stuff can aggravate the lining of the stomach as well. Excessive drinking, smoking. Now, you may think that cigarette smoking, at least, goes entirely into the lungs. You would be incorrect. A fair amount of carcinogens from the cigarettes do end up getting swallowed as well, and therefore, the carcinogens within cigarettes can impact both the esophagus and the stomach. I always remind students that gastritis can also be caused by non-steroidal anti-inflammatory drugs. And I say this because this category of drugs is over-the-counter and widely used by a lot of people a lot of the time. Now, gastritis by itself may not seem like a big deal, but the complications or the pathologies that follow from it can be a big deal. If this is a chronic inflammatory process, say brought about by drinking or smoking or whatever, then risk goes up for gastric cancer, just as risk for cancer goes up in any chronic inflammatory disease. Peptic ulcer disease can occur in the stomach or in the duodenum. And the most common implicating factor is the bacterium Helicobacter pylori. You could almost think of peptic ulcer disease as kind of a continuation of sorts from gastritis. Maybe there's areas of the stomach that got inflamed, and that inflammation just kind of continued on and on till it formed an actual ulcer within the lining or the mucosal and muscular area of the stomach or the duodenum. Now, I want you to check out the clinical presentation of peptic ulcer disease and contrast it between the stomach and the duodenum. This is kind of a useful clinical tool, especially those of you that are going to go on to work primary care. If patients have a history of peptic ulcer disease or are coming in kind of complaining of some abdominal problems, cramping, aches, and whatnot, please remember to ask them if those cramps and aches are relieved by eating or caused by eating. Much like our other assessments and our clinical tools that we use, these aren't positive and indicative of something or the other every single time, but they are useful questions to ask to help raise or lower your suspicion of one versus the other. Do you find that your peptic ulcer disease caused by eating? I don't know. Goes away when I eat, so I never stop eating. I'm not sure. The workup for peptic ulcer disease involves that flexible tube, the endoscope. By the way, when the flexible tube goes up the back door, it's called a colonoscopy. That's basically the same thing. Flexible fiber optic tube. Nice thing about doing endoscopy is that the endoscope can test the ulcer itself for Helicobacter pylori, and patients can be prescribed appropriate antibiotic treatment if H. pylori is found. There's a lot of other H. pylori tests as well. H. pylori in the stool, H. pylori in the breath, H. pylori in the blood. But if you find evidence of H. pylori in those other places, it does not prove that H. pylori is inside the actual ulcer. Endoscopic testing of the ulcer does. So the complications of peptic ulcer disease are kind of similar to gastritis. If it's a chronic inflammatory state, gastric cancer could potentially develop. But also with peptic ulcer disease, you have the possibility that the ulcer itself continues to erode through the lining of the stomach or the duodenum to the point where you get something called a perforation. Your RN colleagues are going to say, "Oh, he perfed." And what perforation means is that there is now a hole, a communicating hole, between the inside of the guts and, in this case, the abdominal cavity. And this is bad because now that means what was in the gut, acids from the stomach, are now getting into the abdominal cavity. That doesn't feel good. And the trillions or billions or quadrillions of microbiota that we have lining our gut also have access to the abdominal cavity. When patients with peptic ulcer disease perf, there is acute pain. You can probably imagine this. Imagine suddenly having your viscera bathed in your own stomach acid. Not too pleasant. So these patients need surgical correction. They need it quick. And also because of the introduction of gut bacteria to an otherwise sterile abdominal cavity, these patients need antibiotics, and they need them quick. Because ultimately, as the acid is washing around the inside of the abdomen and the bacteria are getting in there as well, you can easily develop massive inflammation of the inner lining of the abdomen, and that's called peritonitis, inflammation of the peritoneum. Peptic ulcer disease is a great reminder for me to introduce people to the term Billroth. Over a century ago, Dr. Teddy Billroth was a pioneer of abdominal surgery. His name still graces partial gastrectomies today. There are many ways to remove portions of the stomach and the duodenum. The two most popular are called Billroth 1 and Billroth 2. The biggest difference between them is preservation of the vagus nerve and maintenance of some degree of normal peristalsis. I bring this treatment to your attention because clinically, when you're communicating with your colleagues in a hospital or wherever, they will not say, "Oh, this new patient coming in had a partial gastrectomy." They will say, "This patient had a Billroth."
It's all cold down along the beach.
Now, I don't want you going out thinking that H. pylori is the only way to get peptic ulcer disease. There's other ways to do it as well. A Cushing's ulcer, and yes, it's named after Harvey Cushing. A Cushing's ulcer is a complication of increased intracranial pressure. Contrast that with a Curling's ulcer, which is a complication that burn patients develop. And finally, Zollinger-Ellison syndrome, which is a situation whereby patients have a gastrin-secreting tumor, and the excessive hydrochloric acid that's a result of that causes ulceration within the stomach or the duodenum. These aren't the only examples, but these would be 3 examples of non-H. pylori related peptic ulcer disease. Hey, what did the chronically undecided man say at the divorce hearing? "I can't live her, and I can't live without her." Whenever I talk about common liver pathologies or hepatic pathology, I just like to remind everybody that the liver is massively important. Not only does it detox our blood through the portal venous system and all of the blood coming off of the intestines, it also produces blood clotting factors. It helps synthesize albumin to maintain proper volume within the vasculature. It makes bile for us to digest food. It's very important. Because the liver has so many jobs, when there's something worrisome with regard to the liver, you're going to clinically hear people refer to liver enzymes or liver lab, so to speak. Specifically, liver enzymes refer to enzymes that are measurable in the blood when damage to hepatocytes has occurred. Aspartate transaminase, alanine aminotransferase, and alkaline phosphatase. Most people just say AST, ALT, ALP. Those three labs are kind of analogous to troponins for patients that have sustained heart damage. When cardiac myocytes die, troponins are measurable in the blood. When hepatocytes die, these three enzymes can be measurable in the blood and can be indicative of damage to the liver. Now, in addition to that, you may want to check liver function, and one of the ways to do that is to measure bilirubin in the blood. To go one step further, checking a blood albumin level may indicate how well the liver is able to make albumin. You can do the same thing with blood clotting factors. Lots of jobs mean lots of labs. Now, viral hepatitis might not seem to be the most important pathology to talk about when it comes to liver pathologies in general. However, on the global scale, hepatitis, especially hepatitis B and C, affects hundreds of millions of people globally. So it is worth having a conversation. This slide is meant to contrast hepatitis A, B, and C in terms of the basic path, risk factors, how these patients would present in a clinical setting, the diagnostic workup that would ensue, and the potential complications. So start with the basic path of Hep A, B, and C. It's easy. They're just different viruses. This is called viral hepatitis, by the way. However, the risk factors for getting these three viruses are different. Hep A is transmitted from whoop whoop to woo. Yep, fecal oral. I know, sounds gross. That's how it's transmitted. Contrast Hep A's transmission with Hep B and C. Hep B is infamous for being present in almost every bodily fluid. Hep C, by contrast, is in all bodily fluids, but its major mode of transmission is blood to blood. So Hep C is that classic hepatitis that patients who use intravenous drugs and share needles are at risk for. Now, you might have watched movies and have just figured anybody with hepatitis just gets yellow, meaning they're jaundiced. However, let's contrast hepatitis A, B, and C's clinical presentation. I will tell you that hepatitis A does typically look like a viral hepatitis. It's got three phases. In the first phase, people are really sick as if they had the flu. In the second phase, called the icteric phase, and icteric means yellow, the flu symptoms go away, but then they look yellow all over. Sclera yellow, skin with a yellowish tint, liver's not doing its job, bilirubin is collecting, and you can see its colorful effects played out in the skin and in the urine. You start getting really kind of brownish yellow looking urine as well. However, the good thing about hepatitis A is that it's the kind of hepatitis that just runs its course, and it has a third phase called the post-icteric phase, whereby people are recovering and the most common thing they feel is fatigue. To summarize hepatitis A's clinical presentation, it's the most outwardly visible of the viral hepatitis. How do you say, what's the plural for hepatitis? Hepatitis? What? Hepatitis. So contrast hepatitis A's clinical presentation with hepatitis B. In hepatitis B, 30% of people show no symptoms. However, about 70% of people will show symptoms and go through the classic phases. Contrast Hep B and Hep A with Hep C, where the vast majority of patients don't show any symptoms that they're sick. This becomes really important to consider when you think about transmission. If people don't know they have hepatitis, how are they going to stop themselves from transmitting it? Think about that. In hepatitis A, the diagnostic workup, when it's done, involves measuring immunoglobulins. You don't have to memorize them. Because it's a self-limiting hepatitis 99% of the time, a workup doesn't always need to be done. Hepatitis B labs we will talk about in just a second, so I'll postpone this here. In hepatitis C, testing for antibodies is typically done, and then some type of genetic testing as well, and here's why. You need to find the genotype of your hepatitis C virus, and there's several of them out there, but knowing the exact genotype you have dictates what treatment the patient gets. Now, insofar as complications are concerned, with hepatitis A, there really aren't any. It's a garden variety virus for most people, and even though it looks horrible, they go back to completely normal once the virus runs its course. Contrast Hep A with Hep B and C, where a percentage of B and C patients will go on to develop chronic hepatitis. Chronic hepatitis, as we'll find out, can lead to cirrhosis. Cirrhosis can lead to a ton of pathologies itself. Hepatitis B labs are a very popular thing in nursing school and in med-surg classes. So to make it so that it's not brand new in the upcoming semesters, we're just going to do a little bit of an introduction to it now. To understand the Hep B labs, you first have to understand the Hep B viral structure. And it basically has 3 layers. The inner layer is the genetic material. The genetic material then is covered by core proteins. And when I say core proteins, the other word for that is antigen. And for those of you that may have forgotten, the definition of an antigen is anything that our body will build antibodies against. So you got the genetic core proteins, then another layer of surface proteins, or outside proteins. So that's the kind of 3-layer structure of a hepatitis B virus. When our bodies, or your patient's bodies, see a hepatitis B virus, we don't make antibodies to the genetic material in the middle. We make antibodies to the core proteins / antigens and to the outer shell, the surface proteins or antigens. It's those 2 things that our bodies see and produce antibodies toward. Important concept. Cirrhosis. Always sounded like some kind of medieval knight type thing. Cirrhosis. But it's not. Cirrhosis is an end product to chronic long-term liver disease. Chronic hepatitis, either viral or non-viral, can get a patient to cirrhosis. Non-viral forms of hepatitis can be alcoholic hepatitis, drug-induced hepatitis. There's an autoimmune version of hepatitis, but anytime there's chronic inflammation of anything in the body, long-term tissue changes can occur. In the liver, that manifestation is cirrhosis. Sometimes alcoholics don't necessarily get inflammation of the liver, but instead they get fatty infiltration of the liver. And you might actually hear the clinical term fatty liver disease. Fatty liver disease can be caused by alcohol. It can also occur in the setting of somebody who doesn't drink, and then you get the term non-alcoholic fatty liver disease. But what it means is that the fat infiltrate within the liver ceases to allow the liver to function with a lot of its normal capabilities. If the bile duct or bile tree is chronically blocked, that can lead to liver damage, and if it's allowed to go on long enough, can actually potentiate cirrhosis. In patients with right-sided heart failure and backward congestion of blood, that congestion, if it congests back into the portal venous system of the liver, can actually cause liver damage long term if it's uncorrected. And here's the problem. Cirrhosis itself has a whole bunch of really bad complications. Bleeding from reduced clotting blood factor production. Esophageal varices from portal hypertension. I want to talk about that for a second. But to talk about that, we have to remember about our portal venous system and the venous tributaries all around the gut. Some of the portal venous system actually comes off of the lower esophagus. In patients with cirrhosis, because blood can't return back to a diseased liver, you get portal hypertension, high blood pressure within the portal venous circulation system. One of the complications of that is that the veins around the lower portion of the esophagus start to get engorged. It's basically chronic venous insufficiency, but instead of it being in the lower extremities with varicose veins down there, it's varicose veins in the esophagus. Later on in this talk, I talk about hemorrhoids, and usually when I do this in a live setting, I call esophageal varices the hemorrhoids of the esophagus. They're large, distended veins. The trouble with esophageal varices and large, distended veins in the esophagus is, just like hemorrhoids of the bum, they are subject to trauma. As food's going down the esophagus, it can tear the vein and bleeding can occur. This is a potential source of GI bleeding. And think about it this way. If bleeding does occur, this is a patient who may not be making adequate blood clotting factors. So this GI bleed could be a really bad thing. Suffice to say that esophageal varices are very pathologic all by themselves, and if you go to work with this population, you're going to see that these patients are on all kinds of treatments to prevent esophageal varices from bleeding. They may take medicine such as propranolol to reduce the pressure within the veins. They may have had endoscopic surgical procedures to remove some of the distended esophageal veins. Esophageal varices are a major problem with a fair amount of morbidity associated with them. Now, with all that fluid collecting in the portal venous system from a cirrhotic liver, does it make sense that that increases the hydrostatic pressure of all those vessels? And when I say that, does it make sense to go one step further and to say that the increase in hydrostatic pressure pushes fluid out into the abdominal cavity? An abdominal cavity collection of fluid in patients with cirrhosis is called ascites. In addition to increased hydrostatic pressure from portal hypertension, if the cirrhotic liver isn't making as much albumin, that too can contribute to the loss of fluid from the intravascular space to the extravascular space. Now I'm going to add plus. I added it in there. Can a cirrhotic liver take bilirubin out of the blood to make bile? Nope. Do these patients get yellow? Yep. Can a cirrhotic liver detoxify our bodies? Nope. Can ammonia, which is a neurotoxin, build up? Yep. And excess ammonia can lead to a state called hepatic encephalopathy. Just like with portal hypertension and esophageal varices, if you go to work with these patients, you'll see that they're typically on one or more medicines to help control blood ammonia levels. Now, hypertension from portal hypertension, start again. Now, hypotension from portal hypertension might seem kind of odd. Here's how to make that connection. A cirrhotic liver essentially traps a certain percentage of blood within the portal venous circulation. And in some circumstances, some of that fluid is then getting out into the abdominal cavity. What's not happening is that total blood volume is not being sent back to the heart for circulation into the systemic circulation. So patients with cirrhosis can have portal hypertension, but because that actually leads to less blood getting back to the heart, it's not uncommon to find that these patients have systemic hypotension. And you'll see that when you put the blood pressure cuff on their arm. And of course, hepatocellular carcinoma, because, well, what condition doesn't lead to cancer at some point down the road? Remember, hepatitis is a chronic inflammatory condition. Anytime there's chronic inflammation in the body, the stage is set to promote a DNA-damaged cell's growth and replication. This is no different, and this is thought to be the reason why, in this chronic inflammatory setting, cancer can result. Cancer that is from the liver primarily is called hepatocellular carcinoma. Years ago, I put together a little mnemonic because it was very challenging for students to remember all these multiple complications. So that was when I came up with the phrase, cirrhosis, it ain't no day at the beach. But it's beach spelled with 3 H's, so it's probably not the best mnemonic in the world. But beach is bleeding, esophageal varices, ascites, chronic jaundice, hepatic encephalopathy, hypotension, systemic, and hepatocellular carcinoma. Beach with 3 E's. I might not be, teaching patho, but at least I'm not teaching spelling.